The World Affairs Council of Greater Reading is the leading educational organization promoting understanding and enlightenment on global issues. Welcome back. I am Mike. Let me adjust the view here. So excited to have another great presentation. We've been on a real roll here through these early months as we're dealing with COVID-19. Great presentation today on that exact topic. So I'm glad you were able to join us. We do have the stream running live on Facebook. If you're joining us on Facebook, please like and share that stream so everybody can see it. If you're joining us on Zoom, same thing. If you've got a Facebook account, head over to Facebook while we're getting started here and like and share this post so we can attract as many viewers as possible to consume this great content. I will mention once again, you've received your membership renewal cards. Please get those in. It's a great time to support the organization and get your memberships renewed. Also, as always, we'll have live Q&A with our speaker at the end of the presentation. So as we hear the presentation, please start entering those questions into chat. If you would like to come on and speak live and you've got a camera and microphone to be able to do that, just get my attention in the chat that you want to be able to do that as well. And then I'll help arrange that as we go through the Q&A. And without any further hesitation, I will introduce Saul Lausch to bring our speaker up. You ready to go, Saul?
Yes, I am. And hello, everyone. We're very, very pleased, as Mike has said, to welcome Marie Keim, who is Director of Epidemiology, Infection Control, and Prevention with the Reading Hospital Health System. Ms. Keim has more than 30 years of healthcare experience with over 20 years in infection prevention, including clinical microbiology. Ms. Keim has expertise in all scopes of healthcare encompassing hospitals, clinics, ambulatory centers, and physician offices. She assists clients in all aspects of project design and construction through occupancy to proactively minimize risks for patients and the staff from both the microbiology and infection prevention perspective. We're very, very happy to have you with us, Marie, on this very, very timely topic. Thanks for joining us.
Thank you so much for having me, and I'm so excited to be here. I really appreciate the opportunity to speak to all of you, and thank you for that wonderful introduction. And we'll get started on our slides. I think I need to share my screen, correct?
Yep, go ahead and share. We'll be able to see your slides shortly. And we see them. You're all set up.
Fabulous. So what I thought I'd like to do today is I'd like to give you a journey around the world from A to Z. And I have some objectives that I'd like to do. I'd like to talk about 5 modes of infection transmission, the 4 different types of coronavirus. I'd like for you to be able to describe 3 common signs and symptoms of COVID-19. I'd like to define isolation versus quarantine and what's different between them and the effectiveness. And I'd like to list 5 items that the public can do to prevent the spread of COVID-19 that I'm hoping you all will be able to assist with as we continue to navigate our world events that are currently occurring. So when I thought about infectious diseases and I think about them from an alphabetical order, and I can provide many infectious diseases A to Z that some you may be familiar with, others not so much. And what's fascinating to me from the global perspective, truly going back in history, when we think about huge impacts to society, when we think about cultures, when we think about how did our world evolve, infectious diseases all play a key point. You know, we think about the world wars and other items, but did you think about the infectious diseases that came back from soldiers returning with influenza? Did you think about that 1918 epidemic? Let's go back even further. Think about the plague of Athens. We think about items from Egypt, foodborne illnesses, the Aztecs, Columbus, and what has happened when we arrived here in the United States, and so many illnesses from around the world. A few years ago, if you recall, when we were under the biological concerns, we were worried that from a global perspective, individuals might use something like anthrax, which could be harmful. But in reality, we have anthrax that are also still occurring depending on work-related environments that people work in. We certainly don't even think about chickenpox anymore today. When we think about chickenpox, there's a vaccine. So many of us had chickenpox when we were growing up, and yet today's children won't know what chickenpox is. In fact, our providers, some of the younger ones, may have not ever seen chickenpox. We also know that chickenpox becomes dormant, and then if it's reactivated later on in life, this is actually the same virus that then causes shingles. We go through Europe and we think about the bubonic plague. We think about Philadelphia, and we think about from the construction environment and air handlers and air conditioning. If you recall back in the 70s when we had the Legionella outbreak, that we had no idea what was happening to the individuals attending the convention. A few years ago, many of you may have heard about SARS, the severe acute respiratory syndrome. SARS also originated in China. It was reasonably well contained. There was an outbreak in Toronto, but it really didn't spread throughout the world. And if we continue to think about our diseases from A to Z, polio eradicated, yellow fever and the impact of yellow fever, all the individuals that were impacted with that, the Panama Canal, measles, diphtheria, malaria, which is still vast and a huge issue around the world in so many disciplines, dengue fever, which we see in travelers and individuals going into our warmer environments. We have meningitis that we see. There's meningitis belt in Africa. You know, things that we are safe now with vaccines, mumps. And then we think about norovirus. So, you know, as I've heard about COVID-19 on cruise ships, I think of norovirus on those cruise ships too. And more recently, from a global perspective, a few years ago with the Olympics and in Brazil, we talked about Zika and the impact of Zika from insects and insect bites. So historically, infectious diseases have really driven cultures in society. At that point in time, it was probably harder for them to spread. It took longer for people to navigate, travel, and go around the world. And here we are today. We have a disease that if I were to think about around the world in 80 days, we probably met around the world in 80 days as this unfolded. So who is affected when we think about infectious diseases? Well, everyone. There is no one that is exempt. We all have ways to protect ourselves from hand hygiene, the ways we interact with each other, our animals, our pets, our eating, our food, our handling, and everything we do in our daily events could allow us to be affected. And one of my fascinating books that I've just thoroughly enjoyed, history, I enjoyed history, but it wasn't one of my favorite subjects until I got into microbiology and realized all of the different aspects of infectious diseases that impacted history. And this just happens to be one of my favorite books to go through so many infectious diseases and the impact on society. So when we think about infectious diseases, we think about microorganisms. And when you think about microorganisms, there are 5 main levels and tiers of microorganisms, from our bacteria to our fungus, which includes molds and yeast, to our parasites, viruses, and then our prion diseases. And you know, microorganisms are fascinating. They're fascinating to me because they're good and there are bad ones. And when you think about what we've done to stay healthy and things we eat or use, my goodness, I love my cheese. And in the absence of having all of the yeast, I'd never have cheese. When you think about probiotics and having our good bacteria in our intestinal tract, we want to make sure we have that. Parasites. Most times when I think about parasites, I think that they tend to make us ill. And I don't think of very many viruses that are very helpful. And prions, which are very strong. So this would be a microorganism. So it's strong in the fact of the way that it is contained and hard to destroy. Would be Creutzfeldt-Jakob's disease in mad cow. So our goal is always to balance those microorganisms that are beneficial versus those that are harmful to us. And those even vary according to individuals. So one individual may not necessarily be impacted by that microorganism in the same way that another person may be. And that happens because an infection can occur when the microorganism enters the body, and it increases in number and it causes a body reaction. There's going to be three main items we really think of for this to occur. You need to source. So whether it's a person, a food item, or some other insect, you need a person who's susceptible. So if I were to think about an illness that produces antibodies, so once I've had the chickenpox, I don't typically get the chickenpox again. I would not be susceptible, but a person who's never had it could potentially get that illness. And then you need a mode of transmission. So how does that infectious microorganism get to you to make you ill? Have I eaten something? Did I inhale when somebody coughed or sneezed, and did those droplets get into my mouth or eyes or on my hands and into my mouth? So those are really key items of how we can protect each other and ourselves from those modes of transmission. These are important concepts for us when we're thinking about how to prevent infectious diseases from spreading. They're also very important in the way that we protect ourselves in healthcare to make sure that we're doing the right things when we provide services and care to you. So we tend to think of these items in 5 ways. The contact mode of transmission, which has 2 concepts, a direct mode and an indirect mode. So a direct mode might be, I come in contact with a wound that has pus and organisms in it, and I have an open area on my skin, and I come in direct contact with that and those organisms. An indirect way might be that perhaps a product or an IV solution during the manufacturing process may have been compromised in some way, and that you've had that IV fluid and now you're becoming ill from that compromised IV fluid. The next here that we think of are items that are spread through droplets. For these, I tend to think of influenza, meningitis, and these are larger microns. So, and to me, a micron is greater than 5 microns, very small item. We don't see these obviously, but because of their size and weight, they tend to fall typically 3 to 6 feet around, and they drop to surfaces. So they don't stay suspended in the air and the atmosphere. The next one is airborne. And in these cases, these are smaller in size, and these pathogens, these microorganisms, tend to stay suspended in the atmosphere, and that's how they can be transmitted when individuals may inhale them and come in contact with them into our respiratory tract. TB, I think of in this venue. Chickenpox falls in this category. And this is important to note because as we've learned about COVID-19, it actually falls in between the airborne and the droplet, and we're continuing to learn more about it. Then you have the mode of transmission of vectors. So we think about mosquitoes, fleas, rats. You know, for those of us that like to get outside and hike and walk right now, this is certainly an item when we think about it with ticks. We worry in our area, Lyme disease. So protect yourself. Make sure you're doing all those things you can do to prevent anything as best as you can from being exposed. And then vehicle. So that vehicle is very similar to that indirect contact, and that vehicle might be, I've eaten something chicken that I didn't cook all the way, a water source that's contaminated. Perhaps I've gone hiking and I am drinking out of the river or the stream without a filtration device, and I now have a parasite such as Giardia. Medications or IV fluids or things that are contaminated that have then come into us. So these are the 5 main modes of transmission. And when we're talking about infectious diseases, we want to protect ourselves with every avenue that we can to ensure that we're not becoming ill. So when I think about this and I think about our current state and where we are, and I know there's a lot of information on some of these slides. I'm not going to go through all of this. I want you to look at this because I think it speaks volumes of how much and what has occurred in a very short time frame. So again, this around the world in 80 days concept is truly within this perspective. So in January 2020, the Department of Health had raised awareness to us, and China actually was aware of some pneumonia. And they reported that they were beginning to see illnesses of this pneumonia in a Wuhan province in China in November. And if you're following the media right now, there's some current information that they've been doing some monitoring of some of the satellites. And it looks as though when they were looking at these satellites, just from the numbers of individuals receiving services at the hospitals in those areas, it appears as though this probably even was occurring in October. At least that's what the information from last night has started to say. So fascinating as we learn more. We were alerted by an ophthalmologist in December about a concern of an illness that was SARS-like, recognizing the high risk, the high ability to transfer to individuals, and morbidity and mortality that occurs with that. They did not necessarily receive that information very well when he said this information. So there was concerns that he was speaking up, speaking too much. Wuhan continued to report viral cases. As they went to January, they closed what they thought was a cause of the seafood market. And at this point in time, Pennsylvania, through the Department of Health, through our Health Alert Network, notified all hospitals, healthcare individuals, and providers to beware of a pneumonia that was associated with individuals who have been in Wuhan, and that seemed to be where it truly was occurring. China reported their first death on January 11th. The first case outside of China occurred in Thailand on the 13th. And at that point, the United States began to put in some measures to try to minimize any risk associated with travelers from China. So they implemented some airport screenings, San Francisco, New York, Los Angeles, subsequently added Atlanta and Chicago. In the United States, we had our first confirmed case on January 21st. Wuhan locks down, and we began now in January to see cases in Europe. We heard that the risk was low. It was still continuing. We now knew that they were continuing to monitor since December. And then for the individuals that were returning from China, we had 195 individuals return, undergo review, exposure, and some quarantine processes. January 30th is when the WHO declared a global health emergency. And that same day is when the United States first reported a case of person-to-person transmission. And this was to a spouse from an individual who had recently returned from Wuhan, China. The United States determined this was a public health emergency, January 31st. And we began quarantining individuals who returned from parts of China. It was very significant. This is our very first quarantine that was issued by the federal government in over 50 years. And we really implemented this solely for those flights returning to China and trying to have them go to those specific 7 airports. The first death outside of China occurred in the Philippines in February. We determined the first death in the United States really occurred February 6th, and that was announced in April as we were able to learn more about that patient. The Chinese doctor who alerted us unfortunately passed away on February 7th. February 8th, who announces this name of this new illness as COVID-19. It was known as coronavirus 19, SARS-CoV, but our official name being COVID-19. And on February 12th, the first American dies in China. So I talk about, that was January. You know, as we started to go into February, we realized, I think there was an acceptance. This is real. There's great concern. Transmission is occurring, and we have acceptance that we need to step up measures and that a pandemic is likely. Italy began to lock down as we looked at testing, and we looked at testing in the United States. We had many different types of tests. We rapidly ramped up. We had some test kits that were flawed that were sent out through the different companies, through the CDC. So we had some challenges in making sure that we had testing capabilities across the country, and our different vendors and providers were all working very fast to get us where we needed to be. As of March 9th, we still did not have any community transmission in Pennsylvania. March 11th, there was a travel ban placed for Europe, and who at that point in time declared a pandemic. The president declared a national emergency March 13th for the United States. And we went through April, May, and here we are in June because of coronavirus. So what is coronavirus? Coronavirus itself is a large family of viruses, believe it or not, that cause illness in people and animals. For the most part, the common coronaviruses of 229E, NL63, OC43, and HKU1 are the viruses that cause common colds. We see those every day. There are some variations of some additional coronavirus. The Middle Eastern respiratory syndrome is a coronavirus. It was identified in Saudi Arabia in 2012. And if you happen to remember anything about this, it was associated with camels. So they are zoonotic. They tend to be associated with an animal as an intermediary process to humans. SARS, which was a severe acute respiratory syndrome, that was first identified in China in 2002. They've not had any cases since 2004. And SARS was associated with bats and civet cats. Then we have COVID-19. COVID-19, coronavirus causing infectious disease in 2019, now expanding into 2020. We believe it's associated with rats. They're still doing evidence. There have been other animals. They're looking through all of the different research. It will take time. Research and the information is coming quickly and rapidly. Some of it's peer-reviewed, some of it not as much. Sometimes information is shared and we've had to pull back and we've had to modify as more information comes out. As you know, the greater information we have becomes better and more valuable because we're really able to talk about it in a larger volume versus a small set and a small sample. So with the COVID and the COVID symptoms, they typically appear 2 to 14 days after exposure. It's challenging, of course, because it's very similar to so many other respiratory illnesses. Fever, a cough, shortness of breath or difficulty in breathing. And even some of the additional items that we see, those are the most common three, are still very similar to so many other illnesses. Fatigue, muscle and body aches, headache. Certainly this new loss of taste and smell is one that is unique. A sore throat, congestion, runny nose, nausea, vomiting, and even on occasion some diarrhea. So diagnosing this really is complex. We know many people have little to no symptoms, but there are individuals that do develop very severe illnesses and unfortunately do die from this disease, as we've all learned. Ultimately, 80 to 85% of the individuals have a very mild illness and they do recover. And as so many illnesses that are out there, we do know that individuals potentially could transmit before they demonstrate any signs or symptoms of the infection. So one of the things from a public health perspective, and for everyone to be aware of, as we've navigated it, it continuously changes, staying up with current information, understanding what's fact and fiction, trying to make sure that we are on top of all the treatment and communication to everyone is so important. I've included here one of the very first items that was sent out by the CDC. It initially started off with just, as we've already discussed, China. And within a few weeks, it expanded to China, Iran, Italy, Japan, and South Korea. That if you went to your doctor's office or you were seeking treatment, you'd be asked about these items in these countries. As you can tell from what we talked about in the timeline, it truly rapidly expanded, and it's pretty much, as you know, covered the entire world. So from an individual who might need to seek treatment, it's very important for us, as you would reach out to us in any care at any hospitals and offices and any individual providing services, we're going to ask you, do you have any respiratory symptoms, fever, any travel or contact with a COVID-19 person. It really helps us make sure we can keep you safe in the office areas, in waiting rooms, and for our staff in providing care. We might ask that in person or phone if you're calling to schedule an appointment. And I think we've also learned, we've talked so much about Zoom and technology today, telemedicine. We've really learned the value of this now to be able to still reach out to our patients and be able to treat them. You know, we've used technology in so many ways to help capture blood pressures, our sleeping rate in so many ways. What a wonderful way to help use this and protect everyone in our community. Because the goal is to minimize those risks with any patient in the public. Asking patients to have a mask on, moving people to a private room. There are even options that have provided that you've seen where we may have performed a screen or collected a specimen in car outside and drive-through processes. All important ways to keep our patients safe, keep you safe, and get you to seek the same treatment. We also would, if you're an inpatient, you're going to go into special rooms that have special air handling potentially. We may wear our appropriate personal protective equipment to protect our eyes and our mouth from breathing, especially as we do very invasive procedures where those respiratory droplets might be coming out in large volumes and rapidly. So we want to make sure that we've done that and provided our staff all the items to be safe. And this was just also another example of one of the CDC guidelines that we've all followed as everything evolved, just to show you, identify, isolate, assess, inform. And then if you're healthy enough, go home and instruct the patient how to stay safe, how to not transmit to others, and if you would need to seek further treatment, what to do. I think it's just helpful to understand where we came from and where we are today, recognizing this one was dated February 28th, and here we are in June. So a lot of great information. Things that you may never have heard of, terms that are very common for everyone in the public now. And I just thought I'd share what some of those things look like. You know, you've heard of N95s and respirators, PAPRs, purified air purifying respirators. You know, industry has used a variety of PAPRs and respirators in so many different processes. We've used N95s, the ones on the left, or duckbills in healthcare also for a long time. But in healthcare, you probably might not have seen a healthcare provider wear a PAPR. You may have, as you've seen Ebola, if we've looked at how we would handle outbreaks of that nature. And here we are today in an outbreak in our own local community and the whole world using very similar items routinely. And then once we put them on, just so you know, we do educate everyone and our staff how to take them off safely, because our staff go home, our staff have lives, our staff obviously go home to their families, and we want them to be protected also. And there is a true way of taking off your gloves, when you take off your goggles, an isolation barrier gown that may have been splashed or contaminated on, and that mask and respirator. And then of course, the golden rule for infection prevention, performing hand hygiene or using an alcohol sanitizer to protect your hands and anything that may have been on those surfaces, which we all do. And, you know, it's such a basic concept. I think about so many of these things in protecting ourselves that we've learned all along and should continue to practice. One of the most important things, as we've talked about COVID and how it has spread across the world, and you may have heard this term, R0 or R0. R0 is a reproductive number. It's a statistical mathematical number, and it really indicates how easily an infectious disease spreads from a person to person. Because when you think about if one person can affect two and those two people go and they infect 6, and you look at measles where one person ultimately could infect 11 to 8, the question is where do we see COVID? And as that information was out here, we thought it would probably be somewhere between the seasonal flu and SARS and Zika. And our goal is, because if all these individuals get sick at one time and need to seek treatment and severe treatment and ventilation or ICUs, one of the reasons we do the community practices and interventions we do is to flatten that curve. It allows us to make sure that we are able to provide services to large volumes of individuals, and we don't have as many individuals becoming ill. We decrease those number of individuals who are ill. So if we were to look at that R0 and we look at infectious diseases into the host, Measles is really highly infectious, and that's 12 to 18. If we go down to the list to the influenza in humans, typical influenza is 2 and 4 by this Vox graph. And when you go down to the bottom, third one up from the bottom is SARS, and SARS is 2 to 5 for that R naught. And that is about what we're seeing with COVID-19. And again, as the data continues to come in, we'll really be able to get a clearer picture to see where that does land. And, I mentioned a bit about flu on the grids, but I always thought it's very nice seeing it from a visual as to what that difference would be. So we see the R0, R0, and the COVID is slightly higher, and we're going to say it's probably around that 3 to 4 now as things are occurring. And the incubation time, I think, is also one of those things that really makes a big difference. So flu typically is a 1 to 4. COVID-19 is the typically 1 or 2 to 14 days is what we're seeing. And the hospitalization rate is continuously evolving, and that number is changing very frequently. And I'll give you some resources and tools to see where you can see where that information is readily available to the public across for everyone, whether it's the CDC, the Department of Health, or the WHO. I won't read all of these. And again, we stopped at March. So we talk about R naught, and we talk about trying to protect our public. So our goal was really to protect Pennsylvania. And from a perspective of how do we do this safely and for all in our pandemic plans, in our outbreak management plans, HEMA, Pennsylvania Emergency Management Agency, really activated in March. We had the proclamation of that emergency quickly. And I'd already mentioned that the WHO declared a pandemic on March 11th. And for those of you that are all in schools and in the educational realm, we know that we did the shutdown order on March 16th. And education and businesses have truly changed drastically with this. All non-life sustaining businesses closed in March. So we've gone through so much with pandemic as to how we continue to function safely. We stay at home order, and we've asked people to wear non-medical homemade masks for anyone in the community as of April 3rd to help suppress any community transmission. And you'll see that ultimately through April, there were several other directives. We've talked about what would that opening plan look like, and Governor Wolf talked about his 3-phase planning, and we're all probably very familiar with red, yellow, and green, not just in a stoplight perspective from an outbreak. We know that we in Berks County have been in red, and some of our very local surrounding counties have also been in red with us. Well, a few others did go to yellow a little earlier than us. I won't go into all of the phased reopenings, and you can certainly read this, but some of those concepts that are really important continue to be testing. Do we have the ability to test? What does that testing look like? And what does that testing mean? And how do we continue to monitor for ongoing outbreaks or do contact tracing to make sure that they don't occur? This is where protecting Pennsylvania and thinking about what does isolation and what does quarantine mean? And they do mean different things. So isolation, I typically think of really most times in an acute care environment, but also during this outbreak, it is really for a person who's sick. So it separates a sick person with a contagious disease from people who are not sick. It's usually voluntary, but in an emergency such as this, officials do have the authority to isolate people who are sick. Quarantine separates and restricts the movement of people who were just exposed to a contagious disease to see if they become sick. So they may not become sick, but we're going to try to separate them to ensure that they don't. And when we think about COVID-19, that's a 14-day time frame. So when you think about the R0, think of how many people that person could come in contact with in 14 days. That's what we're trying to prevent. And again, it can be voluntary, but in this situation, it could also be guided by our officials within the government. As I mentioned, contact tracing, when we think about quarantine, contact tracing is an epidemiological concept. And in an outbreak setting, this is to help minimize exposure to individuals who have not been infected. So if there's a person who has COVID-19, part of contact tracing is we need to find out who all you've been in contact with. We're going to ask those individuals to quarantine for 14 days. Should they become sick, they're going to immediately isolate, seek testing, and any other treatment that they may need. And that could be at home. If it does warrant hospitalization, then they would also seek treatment through hospitalization. If that person, that exposed person, does test positive, that entire new contact cycle and contact tracing begins. So this is really a philosophical concept through epidemiology all along. It's going to be very new for people in Pennsylvania and in Berks County in relationship to COVID-19, how we will all continue to work through this. The other two pieces that fall in line with that are from a global perspective. What do they mean and how does it work? So containment was the plan to stop the spread of COVID-19, which includes contact tracing and isolating sick individuals, quarantining individuals that have been exposed to avoid a larger outbreak. Containment is what we've done. Containment is what we've done in Pennsylvania over the last 8 to 10 weeks. And that was because we were not seeing an effective strategy to control that spread of the disease. So that's making sure we have the implementation of social distancing, limiting large gatherings, closing our schools and sporting events. And that was all based on the knowledge we had of what was happening in Europe. As we go into phase 3, we will continue to use some of these concepts over the next several of weeks to months until we get a stable environment that we believe is safe to remove them. So I ask you, how did we do? How did we do with all those interventions that we put in place? And I'm going to show you several different various statistics, and I present them in different ways because everybody likes seeing statistics differently. I'm also going to show them to you because they're presented differently depending on the resource, CDC, WHO, and others. And they also may have some subtle differences to the timing and the way that they're presented. They're all valuable and they're all very close in nature, but I want you to be aware of those differences. So WHO shows a nice case comparison by the continents and where we are. Were we effective and when did things start in February in the Western Pacific and in China and as it migrated across Europe? From the United States specifically, as we look at the number of new cases, and this goes up until I think it was June 6th, you can see that our new cases really began to be affected in March. And then we went and we did have as far as our epidemiological curve, that flattening of a curve, you'll see that it's been relatively stable. It didn't spike up very quick and go very high. It continued to stay in a very stable approach. So from that perspective, we've done well. If you want to compare specifically where we are in Berks County, Pennsylvania, in the United States versus the global cases, the confirmed, the deaths, and those recovered, and they're all important numbers. I think this is a really nice grid to give you a great visual of where we are with that information. And then if you happen to really like detailed graphs and information that is current and up to the moment, I'm going to encourage you to go to the Johns Hopkins data website. This was by chance a group of individuals who had already been working on some syndromic items at Johns Hopkins. So they had these items in place and they were able to continue to navigate and build and grow on this. And I find this as a wonderful way to look at the states for those of you that like nice visuals. And if you look probably at would be the middle row, you'll see Pennsylvania has a relatively reasonable flat curve. And to the right of Pennsylvania is New Jersey, which had a huge spike. And you'll see New York above, which also had that huge spike. I think it's really great to see the measures that we've done as to how we've been able to work through them within our areas as the outbreak occurred and as we've learned from each other. So we were able to use that information from some of those hotspots to drive our concepts and practices. Ohio was a very early state also to implement measures, and you'll see they remained reasonably flat. This just is a segment comparing New York, New Jersey, if you wanted to see them closer by region on a simpler graph itself. And then because we knew that flu was going on, and the CDC has always had also, we report this information every day to the CDC. They capture this information out of individuals with flu-like illnesses. So it's fever, a cough, aches, pains, those different concepts. And you'll see that the blue line, which happens to be COVID, and then the orange line is influenza-like illnesses. So as influenza began to taper down at the beginning of 2020 and in February into March, then you will see how the COVID-like illnesses began to rise and have slowly also tapered down. So this is evaluated and looked at daily as to where the country is. You've all become statisticians and epidemiologists today, so I welcome you. And I'm so happy to have you all part of us. And I think it's important because I'm going to look at you to help keep these Pennsylvania numbers in check. So the good news is 71% of the individuals have been recovered. And these are total case counts that are all complete right now. So you'll see this is really a work in progress. This is the data as of yesterday at noontime. And this shows the cases by the region. As you know, our eastern counties, southeastern areas by purple virtue, we have been much greater than several of our other counties. And if you like looking at tabular format, here is the tabular format that goes along with all of that. The other items that I think are very important, and I think when we first heard about COVID and we heard about the illness, we heard about it in elderly individuals, and we had been hearing that pediatric patients really were not part of the process. That remains true to a point, but what's fascinating to me when we look at our positive cases, we've had quite a bit of positive cases in our 25 to 49 age group, and then certainly our 50 to 64 and 65 and plus. Our hospitalizations, however, do remain most impacted by the 50 to 64 and the 65 plus. But what's also been interesting is we've now had this side illness. I'm going to jump. I'll talk about that in a minute. I'm going to jump to the cases and testing and how we identify that. So you may have heard that there's a wide range of testing kits that's out there. And there's what's known as PCR, the nasopharyngeal swab. That has been our gold standard, and that is how we're testing most individuals to see if you have had COVID. PCR is a test that captures the RNA from the virus. And there's a lot, it's very, very sensitive. The interesting thing about PCR testing is it also picks up dead RNA. So people who test positive, even when their symptoms subside, may continue to test positive for extended periods of time over several weeks to months. So it's, as providers and care individuals in the healthcare, we're always assessing all of the items clinically as well as your testing. So that's the first thing that we've done. And the graph on the right shows you that we've increased our capability of testing as time has gone on due to additional modalities and additional companies being able to produce those items. The newer items that we're hearing and seeing about are the antibody testing. When you have an illness, your body produces antibodies. They're immune globulins, and there are 5 types. I'm only going to talk about 2. IgM is what you produce when you have an active infection. IgG is what you produce after the infection that says you've recovered, and that's what provides you with what we believe to be lifelong immunity. The antibody testing kits are just really becoming available. There have been some that have been out there that the FDA has removed because they didn't work the way they are anticipated. They were only valid maybe anywhere from 30 to 50% of the time. Newer antibody testing kits are becoming available, and they are better. We're hearing that their sensitivity is going to be about 99%. So this is going to probably rapidly evolve over the next week or two. So I believe that we'll be hearing more about antibody testing capabilities as well as the success of those and to how we're going to be able to use this in understanding where everybody's immune status is and where we currently are with COVID-19. For those people that do need to be treated and are ill, it's mostly therapeutic. We treat the symptoms, fever, dehydration, those items. Individuals who are ill and severely ill on ventilators in an ICU, you may have heard about remdesivir, are patients that need that go into a study, and we across the country, this is being used and we've seen success with this. You may have heard information about chloroquine or hydrochloroquine. That's no longer recommended and it's been removed out of the treatment recommendations. The other very exciting things you may have seen in the media and heard about are the convalescent plasma and immune globulins associated by giving those plasma treatments and therapies, which are being done and are also quite successful with the patients that have been receiving them. So really, that was almost a going backwards in time because convalescent plasma has been used in the past, and we've gone back to an old school method and seen success with this. So we've seen a lot of new things and we've seen some old things return in the treatment of these patients.
Yeah, Marie, I don't mean to interrupt, but we do have a bunch of questions coming in from the chat. Is it time?
I'm almost
Can we look
finished.
at-
I think these are my last two slides.
All right.
Multisystem inflammatory syndrome in children is the one unique item that we've started to see. This is not, they're not testing necessarily COVID positive, but this is a fever and inflammation, and these children become very, very ill. But it does happen if they've been exposed to COVID-19 patients. So we are seeing these children, we are seeing them here in Pennsylvania, as well as the country, and we're going to learn a lot more with this as we go forward. So what can you do and what's next? Get fact versus fiction. I won't review these. Please look at them. There's some wonderful items here as to what we've had to dispel truths to give facts. Make sure that you stop the spread of germs. Please follow your social distancing. Wear your mask. Please make sure your nose and mouth are covered. Perform hand hygiene, disinfect things. And if you're ill, please stay home unless you're calling your doctor and have been guided to seek for treatment. Follow our social distancing, help our community be healthy. And I'm depending on you. Our community is depending on you. We're all depending on each other. And this is really part of our community initiatives. My resources are listed here. And I thank you very much and happy to answer your questions.
Excellent. Thank you, Marie. Lots of great information there. We do have a bunch of questions in. We've got over 50 people between Facebook and the Zoom presentation here. So I'm going to reset the screen sharing here a little bit. All right, there we go. So let me just go to speaker view. Cool. Okay, so super quick. Just why do we hear it referred to as the novel coronavirus? What's that mean?
Sure. Novel is a term that it means that this is a coronavirus or an organism we've never seen before. So novel just meant it's new to us, never been seen.
And at what point does it stop being novel?
It's not, I think it's not novel anymore. I don't know.
Okay.
They'll go back and remove that out of the terminology with all of the items that have been used and written at this stage of the game. But it is, you're absolutely right. It's not novel anymore. Novel.
All right. So I guess just for a sense of comparison, like if we, the Black Death, 100 million to 200 million people killed, but that was in the 1300s. The flu pandemic here in the early 60s, the Asian flu in the late 50s, we're talking about 1 or 2 million people. HIV/AIDS, 36 million people. And so here today, yes, we're only 4 to 6 months in, but 404,000 deaths worldwide. So certainly we have more mobility, which increases infectiousness, but we also have faster communication, better medicine, better mitigation. So how can we think about this in terms of like the scope of the disease and the severity of it?
It's interesting because you're absolutely correct. We move very quickly. So if you think back about the bubonic plague, if we could move everybody that rapidly, would those numbers have been much, much higher? Possibly. The flip side of it is we also were aware of this much sooner, so we could put our mitigation strategies in to lower this. I think it's probably going to land, it's really hard to say, but I think it is something because as a community and society, we've never experienced something so rapidly unfolding that has these adverse outcomes so quickly in such a short time frame. That's what I think has really added to our fear and anxiety, rightly so, because it is dangerous. It is very, very dangerous. But we also have the ability to put some of these prevention measures in it. We'd feel better, I think, if we had a vaccine and we knew we could get that. And hopefully we'll see that maybe by December. We're hearing a lot of good things happening with it. That is such a rapid turnaround time to get one, but in the scheme of things globally, I think it's going to land very similar to any other of our 1918 flu epidemics and those items that took large amounts of individuals and caused death worldwide.
Yeah, and you gotta mute somebody here. And Neil Hoffman points out in the chat that if we looked at per capita numbers, it would even shift things. So presumably fewer people in the 1300s than now. So probably, again, by comparison, makes this look slightly less severe, maybe. Kevin Coots asked in the chat, maybe to talk about the role culture plays in combating the pandemic. That comparing to some Asian countries, they've had a lot of success, very few deaths. What do we see cultural? Like, what's the cultural impact on how this is being responded to?
That's a very interesting question. And when I had been in Hong Kong, one of the things that was fascinating, as we all know, in Asian cultures, they wear masks all the time. And I think there's a lot of items that we don't know just yet. So some numbers, and I think it was Japan who said they had had lower numbers for a while and that they had put mitigation strategies in place, their numbers did go up. Some of the other cultural behaviors in some of the Asian cultures are not necessarily as good with their respiratory hygiene. And I remember seeing signs that said, don't spit, don't do this. So, respiratory hygiene isn't always very good. And then you think about the practices with open markets. I would also say when you look at some cultures are not necessarily providing all their data and information. So we have segments of information and data we're getting. I also thought about it in relationship to Italy. So when I think about Italy, and I think about cultures that are very close, when we think about families, very tight knit, I think about rooms and housing and the way that the cities are built with many people and many buildings, very close and very, we hug a lot, we touch a lot, how very easy, that's just part of a routine culture. And that makes those things transfer so very simply. So I think that's why we saw what we did in Italy very, very quickly.
We've got so many questions coming in here, so I'm gonna keep trying to push through these. So it's easy to look back at the initial reporting. Things were moving very quickly. Things obviously were changing a lot. We were getting new information. So part of the question is, what really happened with the WHO and the early reporting on China's numbers? Like, was it flawed, or was it just kind of the nature of things going? It's been exaggerated. And then just generally speaking, with the change in information, like changing guidelines, masks, no masks, this treatment works, this one doesn't, like, how do we know what to believe about all this?
That's a really great question. And I think part of this is the unknown with the COVID-19, and you're trying to do what you're learning as things move. And I would agree, we have had a lot of things that have changed continuously. Sometimes there's evidence to support some of it, sometimes there isn't. I'll answer your first question about what WHO had originally. I think WHO was working with the information that was being provided to them. And I think they were still trying to gather more facts to make that decision that it was a global pandemic. I think in a large scale for the world to identify a global pandemic, also there's a lot of, if we do this, are people going to say it doesn't make any sense, you're making this up, when those numbers and items weren't low? So you're right, armchair quarterbacking, it's really easy to look at now and go back and say, boy, we could have done all these things better, but I hope we learn from it. And I agree, the masking, not masking, we go through that daily with our healthcare providers as it keeps changing. And what I would say is I would go back to the basic concepts. The goal of what your parents taught you when you were small, and which we still teach, are cover your mouth when you cough and sneeze, truly. So whether it's a face mask or if you would have covered it with your arm or your elbow, perform hand hygiene before you eat, after you use the restroom. These are all those basic concepts of preventing the spread of infection. So whether or not I had a face shield on or a mask on or an N95, I should have been doing that all along. So I think some of it is just wordsmithing to get to what the latest information shows, not necessarily conceptual changes.
Yeah, and with respect to the WHO, certainly you can see you could understand reluctance to declare a global pandemic, right? You want to be really sure before you come out and say something like that. So I think to some extent that's certainly understandable. So if we look at the spread, right, it makes sense that infections in general will spread faster in more densely populated areas. So we could see it start in cities and spread out into the more rural areas. Beyond that, we see countries and states with kind of inconsistent containment policies. So how do we maybe see this playing out now with some states trying to open up, other states still staying somewhat locked down? Dave Carroll asks, we've got 19 states showing increased cases that are trying to open up. Like how do we start to get this under the control, or what's the relationship there?
I think that's the big puzzle. I think that's we're all trying to see what happens as we've started to try to remove some of those restrictions. And I think this is where the contact tracing is going to be so important, and asking people to do those basic infection prevention concepts. I think as we begin to have more of that testing, those antibodies, as that becomes more and more sensitive, and we are assured of what immunity type we are, we'll better know truly how each of those locales are that are seeing those numbers go up have been impacted. It's so new, that is really the question. And we're all, that's why we monitor it daily, and, we make changes, and sometimes those changes, maybe we should have waited 2 or 3 days to see what really that meant before we make that change.
And it's easy to see a scenario where as it spreads, it kind of bounces back and start reinfecting people who had been previously affected. Are we seeing any of that?
I don't know that we really have seen much of that just yet. I think it's too soon to really be able to identify anything of that nature.
Okay, so Berks County is kind of an in-between area, right? We've got farms in rural areas, we've got a small city, so we're not New York or Philadelphia, but we're not Iowa. Nothing wrong with Iowa, just an example of someplace more spread out, right? So what's working best for us? What's been like, how are we seeing this? Like Neil Hoffman, for example, says we've been one of the most severely affected areas. Seems to have been kind of a chaotic response, with the presence of a county health department have helped with the initial and continuing response.
Hey, Dr. Hoffman, good question. I know we've debated that many times, and because of covering all of Tower Health facilities, I do have some facilities that are in other counties that do have county health departments. They meet and do discuss and have some standardized processes that are a little bit more consistent. They still are having some of the challenges that we do because of the changing state requirements also, but there are definitely some benefits in those counties that have state health departments locally within them.
Has helped with that. All right, so a bunch of questions now. I'm going to try and go through like a little speed round. So I think you touched on this a little bit in your presentation, current thinking on when we might expect to see a vaccine?
What we're hearing, and latest that I heard earlier today, I think what I read was there is some great hope to have it by December. That is really fast from all of our history and knowledge. And all I can say is I'm very hopeful.
All right, we'll keep going. Neti pots. Bill Litfin asked about neti pots. Any is it an effective means to avoid spread?
I've talked about that with a lot of people. Neti pots is really practiced in many cultures. And to your question with Japan, Japan uses neti pots quite a bit, I believe. And, that could be one of the items that they may have contributed to a low rate. I think it does keep all of the mucus from building up for whatever it happens to be. So there are people who absolutely love them and swear by them.
Okay.
I think it's a personal preference.
Sounds like the evidence is maybe a little bit more anecdotal, but possibly not a bad idea.
Exactly.
Okay. We talked about masks. We talked about no masks. John asks, Are the body oxygen levels lowered when wearing masks for a long portion of the day, since exhaled CO2 is being re-inhaled? I think this is how I feel when I'm walking around the store with the mask on. I just want to take a deep breath, right? What's behind that?
A great question. No, there is no evidence for that. And I will tell you, I am claustrophobic. So let me tell you what it's like for me. I feel that when I try to go grocery shopping and I have my masks on for any of these things, it's a great item for me to work through.
And where are we on masks right now? Like, my sense still is that you wear a mask to avoid infecting other people, and that if you're asymptomatic, that could still happen. Like, what's the current state?
So current state is universal source control. So it's masking of others when you're out in public. If you are not able to keep that 6 feet, social distancing, I think that masking is probably going to stick around for a little bit of time.
So can you rephrase that first part in a maybe more layman's terms?
Universal masking, meaning that you'll wear a mask when you go outside. So universal means everyone should be wearing a mask when you're out in public, that you could be exposing others.
So current advice still is everybody should be wearing masks outside.
Yes, yes.
Perfect.
Perfect.
So asymptomatic carriers, Bill Itvin asks, concern about asymptomatic carriers, is temperature reasonable indicator, oxygen levels, pulse oximeter, all those sound like symptoms that you could look for. What is the truth of asymptomatic carriers as we understand it right now?
Well, I think the challenge with those asymptomatic carriers is they don't have any signs and symptoms, and that is being suggested as to one of the rationales for everybody masking, because that asymptomatic person who doesn't have any symptoms will at least have a mask on, and you also will. So between the two of you, hopefully that's helpful.
And just referencing our early conversation, Dr. Tom Blakely clarifies that the bubonic plague, Black Death, in the 1930s killed 1/3 estimated of the population in Europe. COVID-19 obviously doesn't come anywhere near that, but significant impact there for sure. So thanks for sharing that, Dr. Blakely. Debbie Wang asks, do we still need to wash off groceries?
What I would say here is I'm not aware of anything that has indicated that groceries are a risk or that there has been any association with that. But what I would suggest to you is you should wash the items that you normally would wash. So for example, if you normally get grapes and you wash your grapes, you should continue to always wash your fresh fruit and food items the way that you normally would, as well as cooking them and washing after handling raw food.
Got it. All right. And I think we've gotten through all the questions in chat. I guess my, short of anything else coming in, my last question for you might be, so being in a position to see people coming in and out of the hospital, the trends across the county, what is the thing that you either wish people knew or wish people would pay more attention to in responding to this?
I will say the thing that I see most frequently when I've been out and about is people will wear a mask but not wear it properly. So it's either below their nose, not covering everything. And I think if we're going to do it, let's do it right. Please do it right. And if you're ill, don't go out. I think it's basic common sense principles that we need to follow, and we need to be patient with each other. We need to respect each other, and try to help each other through this, because I think stress and anxiety is so high right now. And I think everybody has to understand we're doing the best we can to keep up with the information as it's changing. We're not perfect. It keeps changing, but we want to make sure we're sharing things and helping all of us be safe and healthy.
Excellent. Thanks so much for joining today, Marie. Really enjoyed the presentation. Thanks for answering all these questions. Clearly a lot of interest in the topic. We've had over 50 people for most of the presentation. Thanks for joining us today.
It's been my pleasure. And thank you so much for asking, and be safe and have a wonderful day.
Awesome. So let's bring Lynn back on for our closing comments and upcoming announcements.
Okay. Marie, thanks so much. We really appreciate a wonderful presentation. And Mike, thanks so much for facilitating as well as you do. We appreciate that as well. Just quickly, some upcoming programs. Next week on the 17th will be the last in our series of great decision sessions, Artificial Intelligence and Data. Dr. Abdullah Konik from Penn State will be our presenter. We look forward to seeing you then. Also on the 24th, a special presentation from Dr. Chris Miller of Tufts University. He's currently been presenting at the Foreign Policy Research Institute. In previous weeks, he'll be there tomorrow if you want to catch him on that network. And he'll be talking about Putinomics, Power and Money in a Resurgent Russia, which is the title of his 2018 book. Then coming up on July 8th, we have Dr. Victoria Hoy from Notre Dame University. She'll be talking about recent developments with Hong Kong and China. And she recently presented at the Foreign Policy Research Institute as well. So we look forward to seeing you for those sessions. And thanks so much for being with us today. We'll see you next time. Bye.